I'll make a couple of apologies before I start. The first is this really isn't a tumor talk. I have not really used multi-rod constructs in tumor patients yet, but anticipate that I will. I don't know exactly how that'll work with the carbon fiber constructs, and that's an interesting question as well. And I don't really have any insights to offer as to how that would work. The second is that this is largely going to be just a case-based talk rather than data-based, and that's because there really is not yet data about the benefits of multi-rod constructs. So what I'm going to focus on is just sort of several patterns to kind of give you some thoughts about how I approach these and how that's changed for me over the last several years. So we know that rod fracture remains a significant concern following long fusions, really for any purpose, but most long fusions in this country are done for adult spinal deformity, leaving out fusions in pediatric patients. These are the numbers from notable centers, including the ISSG data, with at least a 10 to 20 or more % risk of rod fracture over time following longer fusions. We know the risk factors include obesity, comorbidities, infection, revision, 3-column osteotomy is a risk, and lack of BMP appears to be a risk, and patients that are on bisphosphonate osteoporotic medications, that's yet another. Many of these are modifiable, although which in an elective situation like deformity we can work to optimize. That's not the case, obviously, in a number of cancer patients who have to more or less be treated as we find them. And I would add to this, and what we're going to focus on, what I'm going to focus on in this talk is rod diameter, material, and rod number as a risk factor in a way to mitigate the risk of rod fracture. It turns out that construct length is not that strongly related, and I think the issue here, these are all probably comparing two groups, the thoraco-lumbar upper end plate or upper end point and an upper thoracic end point, and really I think the message there is we don't see rod fracture in thoracic spine much. It's mainly a problem of the lumbar spine, and both of those constructs, even though they have different upper end points, include fusion all the way to pelvis. We know the timing, typically these constructs last, and they should last at least 12 months in most cases, but between 12 and 24 months is really where we see the greatest number of these occurring, and that's really kind of a heartbreak for patients because they're just kind of seeing the benefits of the surgery and through the surgery, and suddenly they're suffering again because of rod failure. We did a study through ISSG with Alan Daniels and Tamer Elan from Vancouver, looking at the differences between grading fusion grade versus grading rod fracture. So rod fracture is obvious when it happens radiographically. Fusion grade is very subjective, and we for years have tried to apply fusion assessments. And what we found is that just looking at the fusion mass, the two bars on the left are about equal in terms of clinical outcome indices. And this is the Oswestry data, and you can see on the right that when rod fractures occur, there is a large distinction and a large impact on the clinical outcome scores. That was true for other measures as well. The SRS activity scores, similar, and SRS pain scores, again, very similar. And I wanted to put a plug in for the Lumbar Stiffness Disability Index, which we developed in Portland a number of years ago. And I think this is an index that measures the functional effects of stiffness. I know I'm probably giving Dan Schubas some PTSD talking about it, but the interesting thing here is that patients, when they have a rod fracture, which obviously restores some mobility, actually feel stiffer, and so this shows the overlap between perception of pain and the perception of stiffness effects. So we concluded that really the two main conclusions here are that rod fracture correlates better than fusion grade with outcome measures, and I think the take-home message is that rod fracture often leads to revision surgery, not always. And here's an example of a patient with a unilateral rod fracture with what appears to be a very robust robust spinal fusion mass, and at least by the time of this x-ray had not needed revision, and I don't know the further course, it's not my patient, but it's an example of a patient that has a good clinical outcome despite a rod fracture, so that can happen as well. Here's an example, case example out of my own practice, a woman I operated on many years ago with Parkinson's disease and camptocormia, and we did an upper thoracic to pelvis construct. She was doing very nicely until about 1 year when she developed a rod fracture at the bottom, and we had to take her back and revise that with an anterior to psoas approach at 4-5, and then the domino rods behind. And I will say this is the way I typically will treat rod fracture if it's isolated. If you can find the one level, just patch that level typically anteriorly and then bypass the fracture in the back without revising the entire construct. So how do we mitigate those risks? Again, there are other ways we can do this besides rod number. Osteobiologics, I think, is one that I feel strongly we should use. It probably can't use in most cancer patients currently, but in degenerative situations, I think it's important. Treating them preoperatively and all these other ways of trying to optimize their situation preoperatively. But again, for the purpose of this talk, I'm going to suggest that we span high-risk regions with 3 minimum or 4 rods using currently available implants. So what surgical options may reduce rod fracture? Here's a photo of several of the connectors. This is, again, needs an update. There are several more, and I've always felt that it seems like most implant designs focus on the screws and the rods and the reduction tools and all of those, and then the design team goes out to have a celebration over dinner, and somebody says, oh, we need domino connectors, and somebody picks up a napkin and scrawls out a few designs, and they go back, and they seem to have gotten short shrift a lot of times, but that's changing, and I think that these are now going to be more variable, more robust, and more easily applied than they have been in the past. So here's a few case examples, and for the visitors, that's Lake Union here in Seattle. Lake Washington gets much more attention because it's really a much grander and bigger lake, but Lake Union is really at the heart of the downtown Seattle and was actually the location where a lot of the early neighborhoods in Seattle started. So here's a case example of, from early in my experience starting to go beyond 2 rods. This was a young woman that had developmental delay due to hydrocephalus and had a prior fusion that clearly had failed, and not rod fracture as a result, but rod dislodgement of the upper construct and really terrible deformity. And we basically used I call it a long cross connector. So you can see there's about 4 or 5 dominoes between the 3rd rod and the 2 primary rods, 3 at the top and 3 at the bottom, something like that, 2 or 3 top and bottom, extending all the way from the top of the construct all the way down to the pelvic connector just below the sacral screw. And she did very nicely from that and showed complete healing within a couple of years. Another version is what we call satellite rods. So the 2 words that I use are satellite rod and outrigger rods. And satellite rods mean that the ancillary rods are not connected to the primary construct. And this is actually not an example of that, but the classic example of where that's useful is in a PSO, where you do the PSO and lay short rods across the PSO as you compress and get your correction, and then lay longer rods that don't connect to those rods, but then span the overall alignment. In this case, I did something slightly different, and I would have done it with the technique I just described today. But at that time, these are actually outrigger rods that were placed above and below the PSO attached to the primary central rods. Here's another example of my current approach to instrumentation across lumbar spine. So this is a woman mainly with neurogenic claudication, but with a significant deformity that makes simple decompression not an option. And I now am using dual pelvic screws at the bottom on both sides, using that as the distal anchor for the outrigger rods, and then 2 or 3 dominoes or now dual head screws above, up to the level of at least T12. And I use pretty much the same base construct whether I go to the upper thoracic or thoraco-lumbar junction. This is an example, obviously, of upper thoracic correction. I'm starting to use them now also in cases where we need to cross the cervical thoracic junction. And this is a gentleman I operated on just last week who had a very interesting set of problems. You can see his shoulders are not level, and as a result, he has a secondary scoliosis of the cervical spine. And now he has become stenotic in the cervical spine and myelopathic. And you can see he's having trouble holding his head up and has for years balanced his shoulder inequality and the oblique takeoff of T1 with the compensatory curve in the cervical spine. And this is his MRI. I don't know if that's projecting well, but it does show multi-level stenosis, and he had some signal content in the cord as well, and really weak intrinsics and difficulty with gait. And so this is when I wanted to make sure that we got balanced, and I did his posterior operation first with Ponte osteotomies in the upper thoracic curve. Again, not a very big thoracic curve, but enough to create that oblique takeoff of T1, which was really throwing his cervical spine out of alignment. And I didn't want to realign the cervical spine first because I was concerned that I might not get enough correction to balance that in the thoracic spine. So we did the posterior part, made sure we had good coronal balance, and then came back the same day and did a 3-level ACDF. And here's what his construct looked like intraoperatively. You can see the laminectomy across the cervical segments, and you can see the Ponte osteotomies in between T1 to T7 here. And this is what his correction ultimately looked like on his CAT scan. You can see we nearly corrected the cervical deformity, not completely, but very close, and again, with just enough left to balance the remaining curve in thoracic spine. And then finally, this is an example of implant modularity, and meaning the ability to domino onto the pre-existing implant. So a lot of times now I'm leaving rods long or leaving gaps so that I can access the primary rods at the time of a revision procedure if needed. This was a woman, we went in with a plan to do both cervical and thoraco-lumbar deformity, and you'll see why in the next film, but she had terrible myelopathy, and I think this is about the 3rd or 4th patient I've seen with an upper cervical myelopathy or cord injury resulting in dropped head syndrome, and I think that's a result. The central fibers of the cord at that level are driving the paraspinal muscles before they go to the hands. So it's kind of another version of a central cord deficit, which first affects the paraspinal muscles of the neck before it affects upper extremities. And this is what her thoraco-lumbar spine looked like, and you can see she's one of those patients you can't fit on a standard upright cassette. So we did her neck first because I wanted to make sure we got her myelopathy treated, and she came in with osteoporosis. She'd been on high-dose steroids for a number of years, and we didn't have the luxury, I felt, of using Forteo because of the severity of her myelopathy. But I also augmented, you can see the vertebroplasty cement at the distal end of the construct at LIV and LIV -1, and then we also did a tether in the spinous processes, and despite that, I had a plan that I was going to go back in about 6 months, but we actually were kind of forced to go back at about 3 months because she developed a fracture and worsening deformity at the distal end of the construct. And so this is an example of dominoing on. Those are dual dominoes. I never use only one domino. I might like to extend those even further up into the lower thoracic instrumentation today, and again, quad rod construct below protecting the lumbar fusion. And we did a second stage in her of A lifts at 4.5 and 5.1 below, where I did an extended laminectomy, and she actually fractured or tore the anterior longitudinal ligament at I think it was T1011 or T1112, and so we went in up there and put in an interbody graft as well. And this is what her CT looked like postoperatively from all of that. So where are things headed? I think that's an important new question. I wanted to talk a little bit about a new metal alloy called molybdenum rhenium that has been developed and will be marketed and is being marketed and may change this paradigm that I've just gone through. We may back away from higher rod numbers with this metal. It really is a game changer, in my opinion, in comparison to currently available metals of titanium and cobalt chrome. There are a number of other properties besides its mechanical properties that make it attractive as well. But you can see on the right the load to failure and the larger elastic deformity or deformation gap as compared to prior metals. Its yield strength is much higher. Green here is titanium, blue is cobalt chrome, and the red is the molybdenum rhenium. And here's yet another example, and we can not only is it stronger, it's stronger even when it is in smaller diameter, so it makes a nice option for pediatric patients or for very thin patients, but the size available is going to include 5.5 diameter rods, and the ability to bend a rod greater than 5.5 diameter is pretty limited, so I think that's going to be probably the largest size available of this device. But I think this is something we're all going to want to use in the deformity community as it becomes available and more widely accepted. So in conclusion, rod fracture remains a significant concern in my practice. I think there's a lot of analogies here for tumor patients. I think our implant strategies are changing. A lot of us are using larger diameter, stiffer materials, multiple rod constructs, and increasing modularity of implants with things such as dual head screws and better designed connectors. But stay tuned. I think new alloys may offer sufficient strength to, again, allow us to reduce rod volume and numbers, which is beneficial for our patients in terms of reducing the duration of surgery, the amount of dissection, the risk of placing multiple implants, and cost benefits. So I think that's something to watch going forward. And I'll close with this. This is my son at the World Series. The last time the Cardinals won the World Series, we were in St. Louis, seated behind the dugout by about 4 or 5 rows, and as Albert Pujols was walking off the diamond with the third out, 1 inning, he flipped the ball to my son. My son was standing on his chair next to me, and just in front of us, another spectator.
For these purposes, your call may be monitored or recorded.
That's Albert Pujols.
The spectator ahead grabbed the ball out of the air before it reached my son, and Pujols stopped on the first step of the dugout, and he shook his head, and he pointed to my son, and the gentleman turned around, and he said, "Oh, I'm sorry, I guess this is yours," and he gave it to my son. That's when he must have been 8. Now he's 18. He's about to start college up here with us next year at UW. So thank you very much.
Great presentation. Dan Schuppe here. Question I have is, as what we find is there's always a trade-off with these things, especially biomechanically. There is no secret, right? The secret is there is no secret. So as we put in more rods, and maybe you alluded to this a little bit in some of your cases, and we increase the stiffness of that area, are we also increasing the distal and the proximal kyphosis and failure? And if that's the case, do you have any pointers as we start using more rods and we start seeing more revisions and what have you?
Yeah, I mean, there's definitely got to be a trade-off, right? It's got almost has to be there. I don't know that we've got data to prove that, and we have looked at it. We've tried to in ISSG, and I think others have tried to really address that. One thing I will say, I don't run the quad rod construct the entire length of the construct typically. I think that cervical thoracic one that I showed is probably the closest to doing that. But when it's starting from the pelvis up, I typically am stopping the quad rods at about T12 is my typical stopping point, and my primary construct goes to at least T10 or T9 or then up to upper thoracic. So now, having said that, the primary construct is also stiffer, right? And I'm not a big user of cobalt chrome. I used it early on when it became available. I actually had a couple of late infections around it, which I never see with titanium. I've seen it with stainless steel, but I never have seen it with titanium. And I also found the 6.0 or 635 cobalt chrome extremely hard to bend on the back table. So I've gone back to 6.0 or 635 titanium as my primary metal for the primary construct. And I think simultaneously, really, as we've addressed these issues of rod fracture, we've also, as a community, I think, have become more cognizant of how to prevent junctional problems. And I think there are other techniques that you have to include to drive that rate down as well. But those two complications still remain, for me, the two most worrisome concerns I have in my practice.
Thank you.
Yeah, great overview, Bob, and echo obviously the insightful question of Dan. So one thing that perturbs me as my practice goes on, I see more and more weird multi-level, multi-rod constructs. Is there any effort underway to try to kind of homogenize the use of these so we kind of can teach a little bit more sense rather than just putting cross connectors and a little jiggle jaggle here or there that you're trying to kind of unscramble mentally? It's truly becoming a tinker toy shop out there. So is there an effort underway to try to stratify these thought processes?
So I think that was kind of a polite insult to my constructs, but very eloquently worded. But so I appreciate that. I do think it's becoming more standardized. I showed you, that one case or a couple cases that have kind of my standard 4-rod construct and lumbar spine. That for me is a pretty routine construct. I don't have the same standardization for other anatomic locations, but I think as the implants improve and as our experience increases, I think we probably will define those a bit better.
And clearly not your case, these are not your cases, but I think you have the same experience. We share that clinic space on 1 day a week where we just see all sorts of weird looking constructs that don't make sense.
Yeah, okay, thank you.